I am Prof Foà, Professor of Hematology and Head of Hematology at the Sapienza University in Rome, and we are here in Madrid in occasion of a two-day meeting on CLL and the changes that we're witnessing in the management of this disease. And in this occasion we have the opportunity to have with us three eminent personalities working on this disease, and we're having interviews with them that will be part of this ecancertv program. So I wish to thank first of all Florence Cymbalista, who is Head of Hematology and Biology Department at the Hôpital Avicenne, University of Paris, Frances Bosch, who is Head of Hematology, University of Vall in Barcelona, and Prof Wendtner, who is Head of Hematology Oncology at the University of Munich. So thank you very much for joining us today. So this meeting has been largely devoted to what have been the changes in CLL recently, development of new drugs, and in general I think the theme is that we're probably witnessing a major change, going to more conventional treatment, and in fact, I mean, for the last 30 years it's been mainly chemotherapy and then chemoimmunotherapy, and now we have new drugs which are probably changing the scenario. So I would like maybe if you could start commenting on these changes that we're witnessing. I don't know, Clemens, do you want to start, and then the others will comment on top of this, because I think it's an important development.
I think we're just witnessing a certain paradigm shift within new drugs. These are biologicals. They're quite specific, targeting especially B-cell receptor signaling pathways. It's not like a chemotherapy with many side effects, but they have side effects, but these are limited. I think it's a big chance, especially for relapse refractory patients, and it's also a new avenue, especially for the elderly ones, to get a drug, an oral drug, instead of a chemotherapy, with hopefully very few side effects.
So can we say that we are opening an era when we are going towards mechanism-driven drugs? Because I think that is what we're really talking about. Florence, maybe you would like to comment on this a bit more, because this is really based on the biology of CLL and on our learning over the years of the biology of this disease.
Yeah, I think that's very important, because we are advancing in an area where we are going to treat with targeting abnormal pathways in the cells. So these BCR signaling targeted drugs are going to open a whole new area. It's called chemo-free. I'm not sure it's really something that we should emphasize, but it's certainly going to have different effects, and we see different impact on the patients with the cells going out of the lymph nodes, lymphocytosis, and then going down. And we're going to see also different side effects that I think that we really need to know and to be aware of.
I think we'll come into that, because it's quite a major change compared to chemotherapy. I would like maybe, Frances, to stay always on the biology, because in hematology we're quite used to targeted treatment, and we bring as paradigms of this acute promyelocytic leukemia, which is one specific genetic lesion. Then we have CML and Philadelphia Porter ALL, again the BCR-ALL. But here it's not one genetic lesion, so it's a bit different. We're targeting a different mechanism. So maybe a word on that?
Yeah, the difference between the CLL and other diseases that we don't know exactly the mechanism, intimacy mechanism for.
But despite that, we are.
Yeah, but we are closing the gap between biology and therapy. For many years was separated fields, and now we are closing this gap. We are applying therapies to specific targets, which is the change we are experiencing now.
So really, I think you would all agree we have probably three drugs that are working not as chemotherapies or not chemotherapy. There is ibrutinib, there's idelalisib, and there's a BCL2 inhibitor, ABT-199. So all based on mechanism-driven drugs. And this is changing also our approach too, because you were mentioning, Florence, for instance, lymphocytosis and Clemens side effects. This is not chemo. So the fact that you're having a lymphocytosis, let's go into that first. I mean, this is something we would never see with chemotherapy. Say would you, since you mentioned it, say a little bit more, because I mean, who will listen to this as sort of general practitioners, hematologists on the field? So would this, I mean, if we, in the era of chemotherapy, to have a lymphocytosis, we would think that the patient is resistant, because it would be an indication of a progression of disease under treatment, and that would be an indication to stop treatment. But with the new drug, it's different. Am I correct?
Yeah, it's very different because the cells just go out of the lymph nodes. You know, we know well now that where they proliferate are the lymph nodes. So it's very important to have them out of the lymph nodes. So there is a transient lymphocytosis, and this transient lymphocytosis remains a little bit, but these cells that remain in the blood are not aggressive. So it's another problem for us hematologists also. How are we going to evaluate the remission of these patients with this lymphocytosis which persists in the blood? But the patients are doing very well with this lymphocytosis, and obviously we have to think about the way to now consider how well the patients are after treatment.
So this means also that the B-cell receptor inhibitors are working on the B-cell receptor. It's a different mechanism of action, so it's really controlling the disease rather than trying to eradicate, because you say that the cells can persist. So lymphocytosis due to the circulation of the cells, mainly from the lymph nodes, but you can persist, and in fact, maybe Francesca, you want to comment on that, very few patients with these drugs alone obtain a complete remission. Which is very different from chemotherapy. So it means that the mechanism, we're keeping the disease under control through prolonged treatment. So
yeah, the thing that these therapies are doing is changing the biology of the disease. So as Florence said, the biology changed. Lymphocytes are outside in the peripheral blood. So that's the mechanism that we are doing. That's completely different from other therapies in other diseases where the target was oncogenic event. Here we are changing the biology, so we have to keep the therapy for those patients, and the patient improve, shrinking lymph nodes, increasing the lymphocytosis, which is not a problem, improving cytopenias, so the patients start to feel better in a couple of 3 weeks.
right.
Yeah, we are, sorry.
No, go ahead.
We are cutting the relation between the cells and their microenvironment, and we know that from the biology that they need that microenvironment to survive. So hopefully these remission are going, even with lymphocytosis, are going to stay for a long time, provided that we continue the treatment.
That's the point, provided we continue treatment. So Clemens, this is a major difference. I mean, it's not giving 6 cycles of chemotherapy for whatever. Here we're talking about possibly controlling the disease over time with continuous treatment. I leave it to you.
Right. I mean, that's a new perspective. I mean, maybe it's just a pill like you take an antihypertensive pill every day. But it's also, from a psychology point of view, it's also a shift, because before we had a certain amount of time the patient spent on treatment, a cycle of up to 6 cycles. Now it's a more or less lifelong treatment. And it also puts some burden on the budget, on the health care budget. So this should also be discussed. It's an unlimited treatment, more or less. I mean, until progression, until toxicity. We will talk later about this, I suppose. These are the endpoints, but otherwise it's unlimited.
So I think it's important to stress this major change. So we're going towards, let's say, conventional approaches to a very different approach, where we are keeping the disease under control with prolonged treatment, potentially, let's say forever, potentially, which for CLL is a completely different strategy, more like a CML strategy as it was. And this is a major change. And the end point, at least with the drugs more or less alone, is not complete remission, but is control of disease, and results in patients treated with multiple lines of previous treatment have been very encouraging in this respect. So that is interesting. So I think this need to underline it. Side effects, you brought this out. This is important because since we're giving a different family of drugs, side effects are different. I mean, if we don't get remission, we don't get, let's say, neutropenia, for instance. So probably side effects are different with the drugs. So who would like to start talking? Since you mentioned Clement, why don't you start?
Sure.
I think this is a very important point for just a general
Right.
practitioner, because these drugs will become available. So this will
Right.
be very important.
I mean, these drugs are no smarties, so they are not side effect free. But compared to classic chemo, we do not face, or the patients do not face severe infections in a high proportion.
Right.
There are single patients also having severe infections, but not as with chemoimmunotherapy. But there are also some peculiar side effects with these new drugs. You can get severe GI problems with some of these drugs, also in a small proportion, but you have to tell your patients. You can experience some peculiar bleeding events, although your platelets are fine, although you have nice coagulation tests. So we have to get more experience on these drugs. We have to observe our patients also. These are, I think, important points for the future when these drugs will be available on a very broad way.
So this also means that the pre-screening tests are probably a bit different now with the new drugs compared to what we're used to. You're talking about bleeding, so coagulation. Could this be an issue? Thinking about, CLL patients that are starting treatment or going on treatment usually are in their 70s, so they're not kids. So I don't know, Francesc, would you like to expand on this? Because I think, again, it's an important shift.
It's an important shift because we are learning the new toxicity, so we have to learn what are the side effects of these therapies. For instance, with previous chemotherapies, renal function was a problem. Now it's not problem anymore, so we can give these drugs to elderly people. So other side effects could be, for instance, they are so potent sometimes that can destroy rapidly the tumor, provoke the tumor lysis syndrome. So we are learning these side effects, but in our opinion, these drugs can be spread around to almost all populations of patients with CLL.
Florence, you want to expand?
I'd like to come back to the bleeding problem because from the earlier use, it was decided to forbid the drug for patients who were under warfarin, and it seems that it's more of a platelet aggregation problem. So you have to be, I think that we have in the current year a new recommendation, but it seems that you have to be very cautious with patients who receive antiaggregants. Which is probably a good part of the population in the elderly. So we'll probably have, we have to learn more about that, and there will be recommendation coming.
So that stresses once again a change. I mean, we have to, population, clearly most patients are elderly. These drugs are different mechanism, and so we have to, the screening is not the same as if we were treating with conventional chemotherapy.
And there was also the issue of atrial fibrillation that needs to be sorted out.
I think you made the point, but I would like to stress it again. These are oral drugs. And that obviously, again, for patients who are very often well over 70 and maybe even 80, opens a very important development because there are even logistic issues. I mean, patients in their 80s, I mean, how can they come to the hospital frequently? Who can take them? I mean, there are practical issues which are obviously partly at least overcome by oral treatment. So I think this could be a major help even for the elderly, who in fact are the majority in this case.
Yep.
So if you had to think ahead, do you think we're really witnessing a major change, and this will if we looked 5 years ahead, I mean, if we wanted to guess, where would we be possibly 5 years ahead with these new drugs? Who would like to?
We'll be bankrupt.
Okay, but Clement mentioned this, and I wanted to finish with that.
Yeah.
But let's just keep that aside for 1 second. If we, ideally, how would you think we would position these drugs in a few years ahead? Who wants to start on this?
I think they will be quite widely used because the majority is an elderly population, so I wouldn't say it's the ideal drug, but it's much better compared to what we can offer now. So right now we can offer oral chlorambucil, but this is, I think we agree, maybe not the final solution for this elderly population. So I think in 5 years these drugs will be standard in the relapse setting, especially for elderly ones. I think we have to invest some brain how we can use these drugs in frontline. The best way how we can use it in the younger ones, in the fit ones, compared to very effective chemoimmunotherapies also. Can we combine with antibodies in a good way? Could we even combine 2 new oral drugs, PI3 kinase inhibitor, anti-BTK inhibitor? Things like this should be studied within clinical trials.
A comment from the two of you, do you see it the same? Keeping into consideration also what Clement said at the end. I mean, we are testing combinations, obviously, so how would you potentially see the next 5 years?
I think combination is a very important issue because we have to be probably more efficient for mostly the younger fit patients to try to eradicate the disease using these drugs, and also the combination will be a mean to be able to stop these drugs and not have patients for a lifelong time on the treatment. So there is a lot of work, whether to combine them, whether have a sequential treatment, and explore all the new combination also between new compounds.
Yeah, I would say that this is paralleling the antibiotics, so we have to combine to avoid resistance. So the way to do that is to combine different therapies, so you can prevent clonal selection and prevent resistance to these therapies.
Another important point is there's been a lot of expectations with these new drugs in a special subgroup of patients who represent, in fact, a primary unmet medical need. And I'm talking to patients with a P53 disruption, 17p deletion, P53 mutation. So I would like a comment from you on this category, but this is probably the worst, not probably, without probably, it's the worst subgroup of patients, and we don't really know. So we tend to say if a patient is young enough and can go to a transplant, that is probably the best approach. So I think a comment from you on this, on the possible role of new drugs in this category is very important.
I think these new drugs will also open some avenue for these ultra-high-risk patients.
Yeah.
This might become an alternative to transplantation, to allogeneic transplantation. At this moment, we do not know exactly, but there are patients that don't like the idea of transplantation at all. It's a risky procedure, so these new drugs might also be used frontline for these ultra-high-risk patients.
Yeah, I think this drug will be used frontline very soon for these patients.
Well, in fact, and I think we can say it, the expectation, that the indication might be from European agency that this could be the case, even for the 17p53 mutated, even frontline. If that was the case, as it appears to be, I think this will be a very important step forward, and then we'll really see if we have an alternative to, and we can't transplant an 85-year-old probably, so it's obviously something difficult. I would like to ask you, and then we go to the end of this this interview, what about new mechanism of resistance? Because we're used to chemo, which is different. We're used to other inhibitors in other areas where mutations, for instance, are very important. Do you see changes? Because there's been a paper published already on the possibility of mutation of BTK. Do you see this as a real problem, or too early to say?
I think we are too early to say that there are a few cases that are resistant because there is a lot of pressure for the cells for these therapies, so they are developing mutations. But there are a few cases reported so far, so I think we have to wait longer to know the real mechanism of resistance.
Yes, and if I'm not wrong, these resistance have been seen in a minority of patients and in multiple resistant treated patients.
Exactly.
So we don't know what will happen in first line.
And we still have a very luxury situation that we can also circumvent these resistance by using just the other new drug. That's also new in the situation already now.
It's certainly also a reason for combination.
Exactly.
Okay, just a final comment, because you brought it up, but it is a concern. I don't think we can just disregard it. in general, these new drugs are extremely expensive. I'm not talking specifically of these, I'm speaking in general. And certainly hematology in this respect is a frontliner, effectively so, but to a cost. And I think we can't just forget this. Because the general population is aging constantly in many parts of the world, so we'll see more patients, and the life expectancy is increasing. So a 70-year-old today, at least in Europe, is expecting to live another 20 years because he or she is selected to live. So, I mean, these are key problems. So the issue of cost, I think, will be I don't think we need to really discuss it, but I think it's going to be a very important issue that I don't think hematologists will be negotiated, but I think at the political level this will have to be discussed. We see this around the world, and it's happening that only who can afford new drugs can get them, which is obviously a problem that we'll have to keep into consideration. So I think I would finish it here and say that from Madrid, certainly it's been, I think, another step indicating how the overall management of CLL has changed a lot. I've been around for enough time to see that this is a real major change, and years ago we never even thought of this, particularly as we don't have a specific defect of disease, so it's even more interesting. We're working on a pathway rather than on a genetic abnormality. So I think it's very important. So with that, I would like to thank Professor Cymbalista, Professor Bosch, and Professor Wendtner for being here today in Madrid. So thank you very much.
Thank you.
Thank you.